Tenotomy is the surgical cutting of a tendon, especially as a remedy for club foot. Tendon sheath incision, e.g., for trigger finger. The physician makes an incision in a tendon sheath to release tension in the tendon. For example, this procedure would be performed to relieve trigger finger. The physician incises the skin overlying the tendon and dissects to the tendon sheath. The sheath is incised lengthwise. The incision is sutured in layers. Tenotomy, percutaneous, single, each digit. The physician incises a tendon at the subcutaneous level. The physician incises the overlying skin. The tendon is severed through the subcutaneous tissue. The incision is sutured in layers. Report each digit separately. Tenotomy, adductor of hip, percutaneous. The physician makes a small incision approximately 0.5 inches long over the origin of the adductor muscles. Dissection is carried to the adductor tendon. The physician uses a small blade to release, free by incision, the tendon. The incision is repaired in layers with sutures and strips. A spica cast is applied for 3 to 4 weeks to keep the hip in abduction. Tenotomy, adductor of hip, open. Tenotomy, adductor, subcutaneous, open, with obturator neurectomy. The physician performs a tenotomy of the adductor of the hip. An incision is made starting at the pubis and extending approximately 5 cm along the inner thigh, in line with the V adductor longus muscle. The tendinous origins of the adductor muscles are identified and separated to allow lengthening. The adductor muscles are separated from each other and the obturator nerve is located. The anterior and posterior branches of the nerve are removed. To perform a tenotomy, the tendinous origins of the adductor muscles are divided. The physician repairs the incision in layers. A cast may be applied for 3 to 6 weeks to hold the hip in abduction. Tenotomy, hip flexor, S, open. The physician makes a 10 cm to 15 cm incision overlying the anterior iliofemoral area. The iliacus muscle and femoral nerve are identified and separated. The iliacus muscle and psoas tendon are separated. The psoas tendon is transferred superiorly and sutured to the anterior capsule of the hip joint. The iliacus muscle is also sutured to the capsule. The incision is repaired in layers. Tenotomy, abductors, and/or extensor, S, of hip, open. The patient is placed in a lateral position. A transverse incision is made starting just below the anterosuperior iliac spine and extending to just above the greater trochanter. The gluteus medius and minimus are tenotomized. To perform a tenotomy, the tendinous origins of the abductor muscles are separated. The incision is repaired in layers over a suction drain. Tenotomy, percutaneous, Achilles tendon, local anesthesia. General anesthesia. The physician performs a percutaneous tenotomy of the Achilles tendon. The physician infiltrates the skin and Achilles tendon with a local anesthetic about 1 cm above the insertion into the calcaneus. A knife blade or tenotome held vertically is inserted through the skin and subcutaneous tissue into the Achilles tendon. The blade is turned medially and laterally and swept back forth, creating a nick in the tendon, until the foot can be dorsiflexed at the ankle. Pressure is applied over the incision for about 5 minutes. A dressing and long leg cast is applied with the ankle in 10-degree dorsiflexion and the knee in maximal extension. Tenotomy, percutaneous, adductor or hamstring, single tendon. Multiple tendons. The physician palpates the tendon to be released. A small incision is made to access the tendon. The physician's thumb presses on the tendon to create tension. The physician uses an 11 blade to make a cut through the tendon, releasing it. The incision is closed with sutures. Tenotomy, percutaneous, toe, single tendon. Multiple tendons. This procedure is performed to correct mallet or hammer toe. The physician makes a small incision at the crease of the toe where the tendon is restricted. The tendon is released from the bone and the toe is straightened. The incision is sutured and dressing applied. Tenotomy, open, elbow to shoulder, each tendon. For tenotomy of the distal biceps tendon, an incision is made over the anterior elbow to expose the biceps tendon. The tendon is cut all the way through so as to release the flexion contracture. No repair of the tendon is made. The incision is repaired with sutures. The elbow may be placed in a splint to keep it in as much extension as possible. Tenotomy, elbow, lateral or medial, e.g., epicondylitis, tennis elbow, golfer's elbow, percutaneous. Debridement, soft tissue and slash or bone, open. Debridement, soft tissue and slash or bone, open with tendon repair or reattachment. Tenotomy, shoulder area, single tendon. Multiple tendons through same incision. This procedure may be performed if closed manipulation under anesthesia is unsuccessful to gain adequate motion of the shoulder. An incision along the anterior deltoid and pectoral region is made and the skin is reflected to expose the underlying muscles. The subscapularis tendon is removed from the glenoid rim of the scapula. The physician may also release portions of the pectoral muscle fibers to gain further motion of the shoulder. The incision is closed with sutures and the arm is passively placed in abduction. Tenotomy, open, flexor or extensor tendon, forearm and slash or wrist single, each tendon. An incision is made in the wrist or forearm over the site where the tendon to be cut may be accessed. The subcutaneous tissues and fascia are dissected to reach the target tendon. The usual method is to cut into the tendon so as to allow it to expand and heal as a longer tendon, thereby releasing a contracture caused by the tendon. The tissue layers and skin are closed and a dressing is applied. Tenotomy, flexor, palm, open, each tendon. Tenotomy, flexor, finger, open, each tendon. The physician incises a flexor tendon. The physician incises the overlying skin and dissects to the flexor tendon. Tenotomy, extensor, hand or finger, open, each tendon. The physician incises an extensor tendon in a hand or finger. The physician incises the overlying skin and dissects to the extensor tendon. The tendon is incised. The incision is sutured in layers. Report each tendon separately. Tenotomy, open, hamstring, knee to hip, single tendon. Multiple tendons, one leg. Multiple tendons, bilateral. The patient is positioned prone. The physician makes a longitudinal incision beginning just above the popliteal crease and extending upward. Dissection exposes the hamstring tendons. The tendon sheath is divided and the tendon is incised transversely at 2 levels, 3 cm apart. The physician flexes the hip while the knee remains extended, causing the tendon to lengthen. The tendon sheath is closed. The incision is repaired in layers. Tenotomy, open, tendon flexor, foot, single or multiple tendon, S. Toe, single tendon. A small incision is made on the back of the ankle and a sharp blade knife is inserted into the Achilles tendon and rotated medially and laterally. The foot is forced into dorsiflexion to stretch the tendon to the appropriate length. Direct pressure is applied to control bleeding. A suture is made in the incision and a dressing is applied. Tenotomy, open, extensor, foot or toe, each tendon. A small incision is made on the crease of the toe on the bottom of the foot. The skin is reflected and the tendon is exposed. The tendon is released from its attachment site, allowing the toe to extend. This usually is accompanied by other procedures. The incision is closed with sutures and a soft dressing is applied. Tenotomy lengthening, or release, abductor hall UCI's muscle. A dorsal incision is made over the first metatarsal bone extending to the middle of the big toe. The skin is reflected to expose the underlying soft tissues. The abductor hall UCI's muscle is identified and its distal insertion is removed from the bone of the big toe. This allows the toe to move back out into proper alignment. The incision is closed with sutures and a soft dressing is applied.